Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Imagine you're staring at a CT scan in the ED, right? It's like 2 in the morning.
Always the best time for these things.
Right, exactly.
Right.
And the patient came in after a minor car accident. Functionally, they feel completely fine.
Mm-hmm.
But there it is, just illuminating the screen. You see this massive fluid-filled balloon hiding out in the mesentery.
Yeah, that's a stressful find.
It really is.
Yeah.
Because as the clinician, you are suddenly faced with this really complex dilemma. I mean, that single cyst could be just an innocent, silent bystander, or it could be a ticking time bomb preparing to trigger a catastrophic volvulus.
Exactly.
So welcome to our deep dive. To all the surgeons and doctors tuning in today, our mission here is highly specific. We are executing a comprehensive mechanistic breakdown of the diagnosis, the surgical management, and the underlying pathology of mesenteric cysts.
Right, giving you that highly efficient clinical refresher.
Exactly. But really quickly, before we get into the anatomy and the operative playbook, I do need to explicitly state that this content is for reference only.
Yes, very important.
You are the clinician, so please, make sure you follow your own local guidelines and protocols in your actual clinical practice.
Which is really the perfect framing, because the textbooks and surgical reviews we're pulling from today highlight this remarkable paradox.
Thank you, the rarity of it, right?
Mesenteric cysts account for just a vanishingly small fraction of intra-abdominal masses, like roughly 1 in 100,000 to maybe 250,000 hospital admissions.
Wow.
Yet, they demand an outsized level of surgical nuance. I mean, a single mesenteric cyst can masquerade as, say, an ovarian mass.
Oh, sure.
Or a pancreatic pseudocyst, or even a hydatid cyst. It forces the surgeon to navigate an incredibly treacherous diagnostic landscape.
Well, and the name itself is almost a trap, I think.
Oh, so?
When I was going through the pathology sources, it just struck me that calling something a mesenteric cyst is functionally as vague as saying a patient has an abdominal mass.
Oh, totally. Yeah.
It's an umbrella term based purely on geography,
Right.
Not a single disease entity.
Right. It's just telling you where it is.
Exactly. We're grouping, lymphatic cysts, mesothelial cysts, enteric duplication cysts, urogenital cysts, and pseudocysts all together, just because they all decided to, set up shop within the mesentery of the GI tract, usually the small bowel or the right mesocolon.
Yeah, it is purely a zip code diagnosis.
The zip code diagnosis, I like that.
Right. But to understand how these lesions actually behave in the operating room, you have to look at the embryological origins.
Okay, lay that out for us.
So the pathogenesis theories are directly tied to those underlying histologic types you just mentioned. For instance, the most common variants, the chylous and cystic lymphangiomas, they are fundamentally a failure of the lymphatic plumbing during fetal development.
So the pipes just don't connect properly?
Basically, yeah.
Yeah.
The channels simply malform and they create this closed loop.
I was actually looking at the theory regarding the failure of the mesenteric leaves to fuse.
Oh, yeah, that's a big one.
Because if we visualize the embryology of the primitive gut tube, the mesentery is essentially this double-fold peritoneum, right?
Right, carrying the vital blood supply out to the intestines.
Right. So if those peritoneal leaves don't fuse perfectly during development, a dead space gets trapped between them.
Exact.
And because that trap space is lined with active secretory cells, it essentially becomes a factory that cannot drain.
That factory concept dictates literally everything you see clinically.
Really?
Yeah, because the lining of the cyst is the manufacturing floor, and the fluid inside is the product.
Okay, that makes sense.
So if the trap space is lined by mesothelium, the cyst is just going to continuously produce simple, clear, serous fluid.
Right.
But if it's lined by endothelium, like a lymphangioma, it's tapped into the lymphatic system.
So it's bumping out something totally different.
Exactly. It pumps out this thick, milky, lipid-rich chyle.
So if I'm looking at, say, an enteric duplication cyst, I'm assuming that lining is acting like a tiny, misplaced piece of the GI tract.
Spot on. It's secreting thick mucin directly into a closed loop.
Yikes. And if it's a pseudocyst?
Well, there's no true epithelial lining at all there.
Just fibrous tissue.
Right, just an organized wall of fibrous tissue, probably filled with hemorrhagic debris from a prior localized trauma, or maybe a degenerating lymph node.
the physical properties of those different fluids must completely change the physics of how the cyst behaves in the abdomen, right?
Oh, absolutely. A heavy mucin-filled cyst creates a very different mechanical stress on the bowel compared to a light serous cyst.
Which explains why they present so inconsistently in patients.
Exactly. The extreme variability is exactly why the clinical picture is all over the map.
Which actually brings up something I remember from medical school physical exams.
Oh boy, let me guess.
Yeah. We are all taught to look for the classic Tillow sign.
There it is.
Right. The textbook description is a mobile, fluctuant mass in the abdomen that moves freely transverse to the mesenteric root, but its mobility is severely restricted along the axis of the root itself.
Right. Geometrically, it makes sense.
Sure, because the root of the mesentery runs obliquely from the upper left to the lower right. So the cyst just swings back and forth across that line like a heavy pendulum.
Exactly.
But I have to push back on the actual clinical utility of this.
I don't blame you.
I mean, with the advanced cross-sectional imaging we have today, are clinicians actually relying on palpating the exact swing angle of a pendulum in a patient's abdomen?
The short answer is no, absolutely not.
Yeah, I figured.
The Tillow sign is a fascinating historical demonstration of anatomical understanding, but in modern practice. Physical exam maneuvers are rarely the deciding factor here.
Because the symptoms are just too vague.
Yeah, the clinical manifestations are notoriously nonspecific. I mean, many of these cysts are completely asymptomatic.
Like our car accident patient.
Exactly. Just found incidentally during a scan for suspected appendicitis or a gallbladder issue.
But when they do cause symptoms,
It's usually just a vague, chronic sense of fullness, maybe intermittent pain or some nausea.
right, until the mechanics of that heavy pendulum actually cause a structural failure.
Which is when things get bad.
Yeah, the acute presentations are severe. If you have a massive fluid-filled balloon hanging off the mesentery, it acts as a fulcrum. Gravity and the normal peristalsis of the intestines can cause the bowel to physically twist around the weight of that cyst.
Right, creating a catastrophic volvulus or a bowel obstruction.
You also see cyst torsion, right?
Yes, torsion or spontaneous hemorrhage into the cyst cavity, or even a secondary infection that rapidly devolves into peritonism and an acute abdomen.
Wow. What about in kids?
Interestingly, the pediatric presentations often mimic acute intussusception.
Oh, that's tricky.
Very. Though with the high resolution of modern obstetrics, we're actually increasingly seeing these malformations spotted on antenatal ultrasound.
Oh, before the infant is even born?
Exactly, which gives pediatric surgeons a massive head start.
That's incredible. But let's say that patient is presenting acutely in the ED. The sources make it very clear that baseline laboratory tests offer almost no diagnostic value.
Yeah, pretty much useless.
Right. Inflammatory markers might spike if there's an active infection or torsion, but that only confirms an acute process is happening. It doesn't tell you what it is.
Right. And tumor markers are equally unhelpful.
Unless you see something highly suspicious on imaging and you're actively trying to rule out a malignancy.
Exactly. The entire diagnostic weight basically falls on the imaging.
So starting with ultrasound, what are we looking for?
You're typically looking for a well-defined anechoic or hypoechoic lesion.
Because it's a localized pocket of fluid.
Right, so you'll see posterior acoustic enhancement. You might catch some internal septations too.
But the Doppler is the key, right?
Yes, the definitive differentiator for the clinician is the Doppler. It will show an absolute absence of internal vascular flow.
Which proves you're looking at a bag of fluid, not a solid, highly vascularized neoplasm.
Exactly. Then you move to the CT scan, which really seems to be the true workhorse for surgical planning.
Yeah, you're looking for a well-circumscribed, low-attenuation lesion with thin walls. But if you're staring at that scan, there's a specific, highly reliable visual tell for the chylus variance, right?
Oh, the fluid level.
Yes, because the chyle is packed with lipids,
Right.
the fat physically separates and floats to the top of the water content inside the cyst.
Just like oil and vinegar separating in a bottle.
Exactly. It's a brilliant diagnostic clue.
It really is. And for highly complex cases where the origin is still muddy, MRI is the next step.
How does MRI help specifically?
Well, chylus material behaves very distinctly under magnetic resonance. It throws off hyper-intense signals on T2 imaging.
Oh, so that differentiates it entirely from simple serous fluid or mucin.
Exactly. But, even with all of that imaging firepower, the diagnostic hurdle remains incredibly high.
Yeah, because the fundamental key, the specific criteria you have to prove on the scan is that the lesion is located definitively within the mesentery.
Right. You have to visually separate it from the solid organs.
Trace it away from the biliary tree. Ensure it's not originating from the pelvic adnexa like an ovarian mass.
And even if you trace the geography perfectly, you still don't know the exact histologic subtype.
Right, you can't confirm if it's lymphatic, enteric, or mesothelial.
Not until the pathologist examines the excised tissue under a microscope. Definitive diagnosis requires histopathology.
Which mandates surgery.
Exactly.
Okay, let me challenge that mandate for a moment.
Go for it.
Let's go back to our asymptomatic patient from the car accident. They have a 4-centimeter mesenteric cyst.
Okay.
They have zero pain, normal bowel function, and they honestly feel great.
Sure.
Why put them on the operating table? I mean, why subject an asymptomatic patient to the physiological stress of anesthesia, the risk of intra-abdominal adhesions, and potential bowel complications?
It's a fair question.
Why not just execute a conservative watch-and-wait strategy with, like, serial ultrasounds every 6 months?
It is arguably the most vital question in the decision tree, but the surgical literature is exceptionally firm on this rule.
So no watching and waiting.
No. Surgical excision is advocated once the diagnosis is made, regardless of the patient's current symptoms.
Wow. Because of the mechanical hazard.
That's the first reason, yes. As we discussed, that cyst is a mechanical hazard. It's a ticking time bomb for volvulus, rupture, or obstruction.
So you're operating to preempt a life-threatening acute abdomen?
Exactly. And the second reason is the hidden pathology.
The malignancy risk.
Right. The sources document a small but very real risk of malignant transformation, usually originating within the mesothelial or enteric variants.
And because the cyst is a closed environment, you can't definitively rule out pre-malignant cellular changes without examining the entire epithelial lining under a microscope.
Bingo. Leaving it in the abdomen is leaving a potential malignancy unchecked.
Okay, so the indication is absolute, which transitions us to the operative strategy.
Right, the fun part.
The overarching goal is the complete removal of the cyst and its entire wall, while ruthlessly preserving the vascularity and length of the adjacent bowel.
That's the gold standard. Both open laparotomy and laparoscopy are acceptable approaches, by the way.
Though laparoscopy is heavily favored for appropriate sizes, right?
Yes, just to minimize the hospital stay and recovery time.
Makes sense. So the preferred technique, whether open or laparoscopic, is meticulous enucleation. But if we think back to the embryology we discussed, that failure of the mesenteric leaves to fuse it explains exactly why enucleation is so incredibly dangerous.
Yeah, it's not a walk in the park.
The mesentery is the highway for the blood supply to the gut. This cyst is literally growing inside the vascular highway.
It really is surgical anatomy at its most demanding.
How does the surgeon navigate that?
Intraoperatively, you carefully score the overlying peritoneum and attempt to peel apart the mesenteric leaves.
Just trying to physically shell the cyst out of its bed.
Right, but without violating the delicate cyst wall. And all the while, the major branches of the superior mesenteric artery and the vital venous arcades are draped tightly over and around the cyst.
So you have to meticulously dissect the cyst away while preserving every single millimeter of those vascular arcades.
Every millimeter, because you cannot compromise the blood perfusion to the adjacent bowel.
And the great trap of the mesenteric cyst is that it looks like a simple plumbing problem.
But often it's a vascular hostage situation.
That's a great way to put it. The cyst can completely entangle the blood supply or practically invade the muscularis layer of the bowel wall.
Exactly. And when safe enucleation is anatomically impossible, the surgeon is forced to pivot.
Because you can't prioritize removing the cyst at the cost of destroying the blood supply to the intestines.
No, absolutely not. You will leave the patient with ischemic necrotic bowel, which is a disaster.
So what's the alternative?
The mandatory alternative is a segmental bowel resection with a primary anastomosis.
Right. You have to resect the cyst, the entangled blood vessels, and the entire segment of bowel that relies on those specific vessels.
Exactly.
And the statistic from the texts regarding bowel resection is just a massive aha moment for me.
It's eye-opening, isn't it?
Very.
Yeah.
Segmental bowel resection is required in roughly 1/3 of adult cases. But in pediatric cases, it jumps to 50%. Half of all pediatric mesenteric cyst surgeries turn from a carefully planned enucleation into a mandatory bowel resection.
It fundamentally changes how a surgeon must counsel the patient and prepare for the operation.
You really have to be prepared for the anatomy to dictate the operation.
Completely. And alongside that reality, there are critical operative pitfalls to avoid.
Like what?
Well, the most immediate is handling the cyst with too much force. If the cyst ruptures and spills its contents into the peritoneal cavity, the operation is far from over.
Because if you leave any of that epithelial or mesothelial lining behind, the factory is still completely open for business.
Exactly. It will just continue secreting fluid and the cyst will inevitably recur.
So you must excise every microscopic fragment of the residual cyst wall and irrigate the abdomen copiously.
Yes, copious irrigation to prevent recurrence. Furthermore, once the cyst is successfully enucleated, you are left with a significant physical defect.
A literal hole in the mesentery.
Right. And the surgeon must painstakingly close that mesenteric defect. If left open, it's a guaranteed setup for the bowel to slip through and create an internal hernia years down the road.
Okay, so the ideal path is a clean enucleation or a safe segmental resection.
Ideally, yes.
But what happens when you encounter the true worst-case scenario?
It happens.
Let's say the surgeon opens the abdomen and finds a massive cyst fixed incredibly deep in the root of the mesentery.
Okay.
It's completely wrapped around the main trunk of the superior mesenteric artery. Attempting a complete excision or a bowel resection would cause catastrophic, life-threatening vascular compromise to the entire midgut.
Meaning the patient would lose their entire small intestine.
Exactly. So what is the salvage tactic?
In those extreme, relatively rare situations, the salvage option is partial excision with marsupialization.
How does that work?
The surgeon opens the cyst, empties the fluid, and then sutures the edges of the open cyst wall directly to the peritoneal cavity.
So allowing it to continuously drain into the abdomen.
Right.
But wait, based on everything we've discussed about the secretory lining, you can't just leave the factory running.
You really can't.
My analogy for the marsupialization protocol is that it's the surgical equivalent of salting the earth.
I like that.
If you physically cannot remove the foundation of the cyst, you have to completely destroy it so nothing can ever grow back.
Salting the earth is exactly the mechanism at play. If you marsupialize, the critical non-negotiable step is that the residual cyst lining left behind in the patient must be obliterated.
Obliterated how?
Surgeons will use aggressive electrocautery to physically burn the lining, or they'll apply chemical sclerosing agents.
Like hypertonic glucose or iodine.
Yes, you're actively denaturing the proteins of that secretory epithelium, so it physically cannot manufacture more fluid.
Makes sense. Now, alongside that salvage tactic, our sources included a very explicit, unyielding never list.
Oh yes, the never list.
These are interventions you should absolutely not attempt when dealing with a mesenteric cyst. Chief among them being simple aspiration with a needle, fenestration, or relying on simple percutaneous drainage.
And the mechanism of why those fail is simple. They leave the factory completely intact.
Right.
If you just punch a hole in the cyst or drain the fluid out, the recurrence rates are unacceptably high.
Because it just fills right back up.
Exactly. But more importantly, it leaves behind the tissue that harbors the neoplastic risk. You haven't removed the potential hidden malignancy.
Because the only time drainage is even considered is as a strictly temporizing measure.
Exactly. Say you have a highly unstable septic patient in the ICU who simply cannot survive a 2-hour complex bowel resection.
You might place a drain just to decompress the abdomen and stabilize their hemodynamics.
Right. But it is never definitive therapy.
Okay, so assuming the definitive surgical path is taken, whether that's complete excision, safe bowel resection, or properly sclerosed marsupialization, what's the long-term outlook?
Oh, it's excellent. With a complete total excision, the recurrence rate drops to between 0 and 15%.
That's fantastic.
And honestly, if the cyst wall is perfectly removed, the recurrence risk is essentially negligible.
So the vast majority of patients recover completely uneventfully.
Very much so. Their vague, chronic preoperative symptoms resolve, and they return to their normal lives, especially if the procedure was achieved laparoscopically.
Is there any clinical caveat to that?
Just follow up. If the excision was technically incomplete, or if the surgeon had to rely on a salvage technique like marsupialization, long-term imaging follow-up is absolutely mandatory.
Just to monitor for any signs of recurrence or malignant changes?
Exactly, but overall, the prognosis is fantastic.
It's just a profound testament to definitive surgical care. You take this elusive, highly variable mass, navigate an incredibly unforgiving vascular landscape, and effectively cure the patient.
It really is satisfying.
Before we wrap up this deep dive, I want to leave you with a final provocative thought to chew on.
I'm ready.
We explored the embryological mechanism of these cysts, right? The microscopic failure of lymphatic channels or the failure of the peritoneal mesenteric leaves to fuse properly. If these cysts are born from tiny mechanical errors during fetal development, how many of those microscopic anomalies exist completely harmlessly in the general population?
That is a wild thought.
Right? Like how many of us are walking around right now with a millimeter-sized fold of unfused mesentery, or a tiny closed-loop lymphatic channel that simply resolves on its own?
Or just never secretes enough fluid to cross that 1 in 100,000 threshold where it actually demands a surgeon's attention.
Exactly.
It forces you to realize that clinical disease is often just an anatomical variation that finally broke the surface. The vast majority of these embryological missteps remain entirely silent.
The ultimate silent masquerade.
Well said.
Well, that brings us to the end of today's deep dive. To our listeners, if you found this mechanistic breakdown valuable, if it gave you a crucial clinical refresher, or sparked a new way to visualize abdominal pathology, please do not forget to share it with at least one of your colleagues or friends to spread the word.
Yes, share it around.
The best medical knowledge is the kind that gets debated and discussed in the break room or at the scrub sink. Also, make sure to check out our YouTube and our other social media pages for more content.
Definitely.
And definitely take a look through our back catalog. We have previous seasons and episodes featuring some highly relevant, deep-in-the-weeds medical topics just like this one.
Some really good stuff in there.
Until next time, keep questioning the obvious. And remember that sometimes the hardest part of the operation is just figuring out exactly what you're looking at.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.